Welcome to the ResearchWorks podcast, broadcasting live from the Oceania Academy of Cerebral Palsy and Other Childhood Onset Disabilities Conference 2026 in the beautiful city of Hobart, Australia. Join Dr. Dana Poole and the ResearchWorks team as we bring you an exclusive series of interviews with visionary keynote speakers and leading presenters, captured right here amid the groundbreaking discussions and innovations shaping the future of disability research and care.
Welcome back, everyone. We are here in the conference hall for Oceania in 2026, Hobart, Tasmania. And we've had a full day of great conversations with some pretty incredible speakers. And our last two for the day are no exception. So Nez, I am starting to panic with saying your name. I'm so sorry. So on our panel today, we have Johan Jarl. Did I say it correctly?
Johan Jarl, but it was close enough.
Yeah. Sorry. I'll practice that more. And we also have Ann Alriksson-Schmidt.
Yes.
Did I say that okay?
You did.
Pretty close. Yeah, thank you. Thank you very much. I told you I'd panic, and I always panic. It's a thing. And I love how you gave me an out. You can just say Johan Jarl, which is what everyone says, but I really just didn't want to do that. At least I gave it a go. Both of you are on this conference panel today because I was really interested in the title of your presentation, because it's something I haven't seen very much yet. And it's such an important area. It's titled Educational Outcomes of Adolescents with Spina Bifida in Sweden. It's an area that we often don't see reported, but we know it's crucial. As a clinician working, we know these are topics that come up a lot. What got you into this area to look at this set of data in particular?
I can go ahead.
You start that.
All right. Well, basically, it's been known for quite a while that kids or adults too with spina bifida and hydrocephalus tend to have a cognitive profile that makes it possible, at least, that there would be some academic difficulties. There is some executive dysfunction, and in some cases, there's some other issues also. So we have a follow-up program in Sweden where we encourage, or basically we recommend that all kids at specific ages do cognitive testing. So we've started that a number of years ago. We don't have that much data yet, but we also have bigger we have a bunch of different registries, and we had access to, through a research project that we were doing, data on basically educational outcomes, both for cerebral palsy and for kids with spina bifida.
Right.
So Johan, you want to talk a little bit about the data source?
Yes. So in Sweden, we have large administrative registers covering everything from healthcare utilization to income, employment, and all these benefits and whatnot.
Sure.
And of course, then also grade registers.
Yes.
So
very well known for it, actually. Yes.
So, and then we also have the possibility to link between them. So we were able, or we can identify everyone with a certain diagnosis through the health registers. So in this case, cerebral palsy and spina bifida. And then we can follow them over time, over the last maybe 20 years in terms of different forms of outcomes.
20 years?
Yes, that's in the late 90s, early 90s is when the registers starting to become good enough to use.
Sure.
So that gives us about 20 years of follow-up.
And are there many registers on spina bifida around the world? It's quite unique.
Not as many as for cerebral palsy. We have one that's been around for quite a while that is based on the CP registry, CPUP in Sweden. There's an MMCUP that we worked on for, 20 plus years. It's a little bit trickier because, it's tricky enough for cerebral palsy, but for spina bifida, you have other disciplines too. So neurosurgery, other kinds of surgeries, and a bunch of other specialties that need to go into it. So in Sweden, we've had it for, I can't remember exactly, I think 2007, is when we went national. But there's a registry in the United States that is clinic-based. I believe it started, I was working in the U.S. in 2010, and that's, I think, when it started. But it was clinic-based. And then I'm not following that very closely anymore, although I have colleagues who work on that. But it's basically different clinics where they have multidisciplinary centers in the U.S.
Okay.
So they do collect data, but it's not population-based the same way.
It's very unique then. So what's your background that brought you to here? You're a clinician by background.
No, I'm not a clinician. No? I'm a developmental psychologist, and I also have a background in public health.
Right.
So epidemiology and psychology. So I've worked in the U.S. at the Centers for Disease Control and Prevention with spina bifida. And then when I moved to Sweden, basically I've been doing research and, supervising students and things like that.
That's great.
Yeah.
And yourself?
I'm a health economist, so my background is in economics, focusing on health and healthcare utilization, health-related behaviors. So I've always been interested in societal consequences of disease and disability in this case. So I think coming into this project, Ann and I came from different angles. I'm more interested in, so how does this affect individuals in the long term, their ability to participate in the labor market, for example. And if you fall behind in school, of course, your future lifetime outcomes is going to be affected. I know, maybe now I'm talking for you, but you're interested in cognition as such.
Yeah. It comes together really nicely, actually, doesn't it? And and I love that you've come from those angles too, because we talk about multidisciplinary teams, and yes, we can throw that term out a lot, but looking at it from different perspectives is so crucial, especially when you're looking at implementation as well, which is the next piece of the puzzle. And it's not every day that you can have outcomes that really do matter from a funding perspective, for example, and health economics. If you don't have that piece, because at the end of the day, if people want to know, well, how much will it cost and how much will it save us? It comes down to that sometimes.
Yeah.
So let's get into this work then. What was the main goal or objective of this particular paper?
Well, I think this particular paper is very explorative. We didn't know how children with spina bifida and adolescents, because we go up to 18-year, basically, end of secondary school in Sweden. We didn't know how they fared in school, basically. We couldn't find any information on this. So this was really a first starting point. What happens to them? Do they finish school?
Yeah.
And to what extent do they, fulfill the different types of achievements we can see?
Yes. That's really important, isn't it? Give us some context around the education system in Sweden. What does it look like for adolescents with spina bifida there when they attend school? What does that look like?
Well, it depends a little bit. In some cases, it's just sort of regular school mainstreaming, but there are specific high schools. I think there might be 4 in different parts of Sweden. So there's one down kind of close to where our university is, where it's primarily kids or adolescents with cerebral palsy, spina bifida, kind of, I don't like to call them mobility disabilities, but disabilities that tend to affect mobility to some extent. Right. So they can choose to go to that school.
Okay.
And it's high school in Sweden is typically 3 years, but that program is 4 years, so they can get a little bit more time. But other than that, it's and they also have PTs and OTs and on staff, and it's a boarding school, so they actually live there. So that is one option too, if you don't want to go through regular school.
Yeah. And the actual educational outcomes are reported in the register? What does that look like? What sort of information?
Not in the spina bifida registry, but in the
grade register. That is a part of Statistics Sweden's yearly
so for everybody,
register,
not just for...
No. Right, okay.
So all grades.
Yeah. So we had a tendency over the decades in Sweden where, when I was in school in the 80s, 90s, you had the separation between, classes for typical developing children and classes for children with learning disabilities and who needed more support. And that was changed. So that has been a trend that combining these classes. So that has been a trend over, 20 years maybe. And now we're starting again to see a kind of a differentiation between it. I'm not saying it is to the extent it was 40 years ago, but it's starting to separate again.
Okay.
So this type of adaptive schooling is kind of hard to observe because they're part of the normal teaching situation.
Okay.
So sometimes, and in the registers, it could be a bit hard to discern if they are following a normal curriculum or if they're following an adapted curriculum.
I see.
Yeah.
So there was a lot of sifting through lots of data, combining information from registers as well, which is no small thing. Is that quite a complicated process?
I'm going to say yes, but it's primarily Johan who's been doing it. But it is. And just getting the data takes a lot of time because you have to have an ethics approval and then you have a lot of other steps and a lot of other approvals. So we're actually submitting a new request for data. And I don't know, it's probably going to take a year or a year and a half maybe.
Wow.
Because we want to get some more updated data, but also just data on more variables than we have at this point, including data on siblings and so on and so forth. So it's quite a process.
You have to really think about exactly what you want because you don't want to go into it again, do you? It's a lot to go through.
Right.
Okay, so when it comes to the results from this particular study, what were the main findings?
Well, so the main findings is, not very surprisingly, that in terms of being assessed according to the standard curriculum is you have a lower probability of that if you have spina bifida. You have a lower probability of fulfilling the requirements for continuing to secondary school. And if you're attending secondary school, which you have a lower probability, moving forward to university or fulfilling the requirements for that. Okay. We can also see a difference in terms of grades, grade score.
Okay.
But I would say that this was very explorative and not very surprising. But what was more interesting is, I think, and now I'm doing it bullet point here, that we would expect intellectual disability, which is co-occurring in this population, to influence, and it does. But there's still a huge, even when we control for intellectual disability, there is a huge difference between children and adolescents with and without spina bifida.
Right. And how does that relate to hydrocephalus as well? Children with and
that's the thing, because when you look at spina bifida, in particular in the kids or in the adolescents we looked at, most of them do have hydrocephalus, and that is what's driving not maybe so much intellectual disability, because in spina bifida, compared to, we keep referring back to cerebral palsy, it's not as common with intellectual disability. It's more common than in the general population. But it is the very specific cognitive issues, and that's been known for 25 years. There's a lot of work. Jack Fletcher and Maureen Dennis back in the 90s did a lot of work, and I think at least Jack Fletcher, I think, still does. So there's a lot of good research. So it's very well known that there is a cognitive phenotype. And when it comes to school, it is also, we haven't been able to look at like what subjects are the hardest ones, but I think we can probably make an educated guess that it's going to be related to math, because that is already pretty well established that that's the kind of cognitive difficulties that are present. So it tends to make math more difficult. Reading can be affected, but not to the same extent. So one of the next things, since like Johan was saying, this is exploratory, but it would be very interesting in this new data set that we get to kind of really dig into specifically what it is.
Yes.
But I think we already know that there are specific difficulties cognitive-wise that will make specific topics in school more difficult.
And that's so important, isn't it? When you're thinking about extra supports, where you're distributing funding, resource allocation, it's vital that is understood early, because I'm sure a lot of parents also, when they're sending their children to school from an education perspective, they want to be able to know what prospects they might have and where they might thrive best, I suppose, becomes the next question.
Yeah.
I love a good exploratory study, but it leads to more questions, doesn't it?
It does. Yeah. And we're writing this up now for as a paper. And it just like, we should look at this. We should look at this. We should look at this. But one main point is that, and I don't know if you were getting into it, but if you don't have hydrocephalus, most kids with spina bifida, myelomeningocele have hydrocephalus. But if you don't have it, I don't think we really saw a big difference with the sort of the typical the comparison group. So it is the ones with spina bifida or myelomeningocele and hydrocephalus that
What's
have.
The portion of children with spina bifida that have hydrocephalus versus not? Do we know
in
those
our
numbers?
sample, it's quite even, a bit more. 55% maybe now. I'm making up number, but a bit more than half have hydrocephalus.
And that's quite low if you compare it to international measures. I don't know if we're missing some. We've been looking into that a little bit because normally you would see between 80 and 85. But these days too, now these are adolescents, but these days there's also this in uterus surgery that you can do. So there are special clinics, I'm sure you have that here, where they close the lesion in utero, and then hydrocephalus is not as common. Now, this is not my area of expertise, but it's been around since, I think, probably around 2010 as well. There was
so we might start to see those trends.
I think so.
I mean,
because it's almost like the kids who are born now and have that surgery, they're going to be a different population from what we're studying here.
Yeah.
So there's going to be some I think, cognitive differences as well.
Sure. Which makes this register even more important than ever to understand this population, the epidemiology of what we're seeing. Okay, so is there any other results that jumped out at you, surprised you, or led you down a path of more discovery?
Well, one thing is when we look at the group, children and adolescents with spina bifida in itself and variations within this group, is that the variation within the group is at least as large as the variation between children with spina bifida and without. And hydrocephalus is a large part of this, but we also see that when looking over the different types of spina bifida diagnosis. For me, I think the take home would be that, the huge variation within the group, and going forward and starting thinking about, okay, so what interventions are available and what could possibly be done, that would have to be very, very specific to the individual.
Really interesting work. I can tell that you're going to embark on a lot more work as a result of it. What will be your main take home then for the clinicians or the community with regards to this work that you really want to get across?
To make sure that neuropsychological testing is available early and that you do it more than once, in particular when there are different transition periods. So in Sweden, it's recommended before they start school.
Sure.
And then when they go from basically from I guess 6th grade to 7th grade, which is a transition area when you tend to switch schools.
Sure.
And then we have some recommendations also in adolescents. We try to keep it as basic as we can. I mean, we would love to have more, but it's hard enough to get that implemented. But also we're adding for adults to actually have some assessments. But the thing is, obviously, an assessment in itself means nothing if you don't take the results and actually do something about it. And that's what's important.
Yeah.
And that's, I think, the next step, how you take the results. Because in particular with spina bifida, you will have most likely some strengths and you will have some weaknesses in most cases. So basically how you can come up with evidence-based ways of using the strengths to support the person.
Yes.
And not, to the extent that you can, don't focus too much on the weaknesses, because you can waste your whole life working on specific things.
Yeah, but how can you
just gonna
bolster up those strengths?
Exactly.
Yeah.
So that's, I think, the main take-home message, to really have neuropsychological testing available,
yes,
but also that you actually act on the results that you get, because otherwise it's
just an assessment.
Yeah, you get a number
assessment, right? You sit through a long assessment to do. You want it to come to life, and this is relevant not just in Sweden. This goes across many countries that can take on this advice, which is really important, isn't it? Yeah. Johan, any final thoughts from you as well? Final messages?
No, not really. I think we earlier also did a similar study for cerebral palsy and found similar results there. And what was interesting there is we had a bit more opportunity to look at specific classifications related to the disability.
Okay.
Moving forward with something similar here in terms of spina bifida would also be very interesting to more try to pinpoint it.
Yeah.
Now we're working very much with diagnosis.
That's what. Yeah, that's true. And there are classification tools that are coming out now.
Exactly, and diagnosis becomes very blunt instrument.
Yeah.
So we need to find a bit more precision in what we're doing.
Yeah, that feels like a common theme. Yeah, trying to find the precision. But that's science, and that's the part that drives us to be more curious about the next step, isn't it? Well, thank you so very much for sharing your work with us today, for presenting at this conference, for making the effort to come all this way as well, because I know it wasn't easy.
It was easy coming here. It's going to be hard going back.
Well, at least Australia's a nice place to be in the meantime.
Definitely.
The weather's been fabulous here as well. It's wonderful to be in Hobart. I thought it'd be a lot colder, but maybe I'm speaking too soon. But your cold is very different. I just realized as I was saying that.
I just basically have short sleeves. I was expecting heat.
So you're expecting heat.
And sunlight.
Yes. So, what season is it when you head back to Sweden then?
Well, when we left, it was, we live all the way down south. Okay. So it doesn't get that cold, but we had quite a bit of snow this year. And I think it was -2, but it was very windy. So it felt like, I don't know, minus 20.
This would have felt
but now they say the spring has arrived while we've been here. So.
Sure.
That's what they always say, isn't it? As soon as you go away, they always go, the weather's turned. It's wonderful.
Yeah.
Well, you've got great weather here. So it's lovely to have you here. Thank you once again. And to all of our listeners, hope you really enjoyed that episode too. There's so many great take-homes there. And I love how we've been able to share a very distinct recommendation as well in terms of neuropsych assessments at these 2 time points to support our kids with spina bifida. But there's so much more to come. Hope you keep enjoying these episodes. We'll talk to you all again really soon. Thanks and goodbye.
Thank you.